short essays. We are focusing on most commonly asked questions. These one-time asked questions I am skipping. I'll be sharing this PDF with you all. You can study this afterwards. The things which I have marked with highlighter will be discussed now. First, I am discussing acute nephritic syndrome and acute glomerulonephritis. Okay, let's start with acute nephritic syndrome. Before starting with acute nephritic syndrome, I'll talk about glomerulonephritis in a whole. Now, what is glomerulonephritis? Glomerulonephritis, the term itself indicates glomerulonephritis. It's the inflammation of glomerulus caused by immune damage. The definition goes like this: the inflammation of glomeruli, and most are due to immunologically mediated injury, is called glomerulonephritis. The immune cells will attack the glomerulus and cause injury. This is called glomerulonephritis. In the glomerulonephritis, we have spectrum of disease ranging from acute to chronic. We have acute proliferative glomerulonephritis. We have rapidly progressive glomerulonephritis. We have chronic glomerulonephritis. Now let's connect glomerulonephritis with acute kidney injury, chronic kidney injury, and rapidly progressive renal failure for ease of understanding. Yesterday, I discussed many causes of acute renal failure. Those are pre-renal, renal, and post-renal. In pre-renal cause, I emphasized on tubular causes, but I missed some things that are glomerular, interstitium, and vascular causes. I'll be telling that to connect with this topic. The glomerular causes of acute kidney injury are acute post-infectious glomerulonephritis, lupus nephritis, IgA glomerulonephritis, Goodpasture syndrome, Wegener's disease. Interstitium causes are infections and medications. And then vascular causes are bilateral renal artery stenosis, bilateral renal vein thrombosis, and small vessel diseases like vasculitis, malignant hypertension, atherosclerosis, HUS. Here I am simply mentioning all these topics because each topic, it's a discussion, it's a short essay in itself. So I am simply briefly mentioning these causes. We will see each of the causes, why they lead on to acute kidney injury, how the pathophysiology goes on as we discuss the topics. So these were the causes of AKI, which I mixed. The renal causes. I told you the renal causes are tubular causes, that is ATN, AIN, that I explained the previous day. And then we have glomerular causes, interstitial causes, and vascular causes. Let's continue. So, acute kidney injury. Acute kidney injury or acute renal failure, acute kidney failure. Kidney failure occurring in hours to days. Rapidly progressive renal failure is the kidney failure which is occurring in days to weeks. Chronic kidney failure or chronic kidney disease is the renal failure occurring in months to years. The timeline goes on increasing as we go from acute kidney failure to chronic kidney failure. Acute proliferative glomerulonephritis, which I mentioned here, will cause acute renal failure. The rapidly progressive glomerulonephritis, which I mentioned, will cause rapidly progressive renal failure. The chronic glomerulonephritis, as I mentioned yesterday, will cause chronic kidney disease or chronic kidney failure. This is the connection between renal failure and glomerulonephritis. So let's see each one separately. First one, acute proliferative glomerulonephritis. Acute means we mentioned it's occurring in few hours to days. Now, what is the meaning of proliferative? This term proliferative. Proliferative term means there is increase in cell numbers due to hyperplasia of one or more of the resident glomerular cells with or without inflammation. Let me explain. We have glomerulus, glomerular tuft. In the glomerular tuft, we have this endothelium endothelium and cells. Normally here we can see nucleated cells. Here I am zooming in. Normally we can see one or two cells here, where inside the glomerular duct there are more and more cells seen inside this glomerular duct. It's called as proliferative, which is an histopathological finding. Okay, let's continue. I mentioned what is proliferative glomerulonephritis. We all know acute proliferative glomerulonephritis or acute nephritic syndrome. We have one of the 5 marks question mentioning acute nephritic syndrome. Under that, you can answer as acute proliferative glomerulonephritis. What is the etiopathogenesis of acute proliferative glomerulonephritis? Acute proliferative glomerulonephritis is most commonly caused due to immune complex deposition and then followed by that immune cells attacking it. I will repeat it. The acute proliferative glomerulonephritis is most commonly caused by immune complex deposition, which is followed by immune attack. This immune complex deposition is somewhere in the body. The antigens are present. It can be exogenous, endogenous. The antigens are binding with antibodies produced by B cells, and these two things are already bound. But when they are filtering out in kidney, they are getting deposited in the subepithelial layer. Subepithelial layer. Let me explain what is the subepithelial for you. In the glomerular basement membrane, we have capillary endothelium, followed by lamina densa, followed by podocytes. So why I'm explaining it is to make you to understand the major difference between nephritic syndrome and nephrotic syndrome, which is very, very important for our understanding. The glomerular basement membrane has capillary endothelium, that lamina densa and podocytes. Here, if the immune complex deposits and the immune injury occurs at the subepithelial layer, it leads to nephritic syndrome. If the immune complex deposition and injury occurs at the level of sites and near to it, adjacent to it, it leads on to nephrotic syndrome. Nephritic and nephrotic. So this is the major etiological difference between nephritic and nephrotic syndrome, which is the cause for different varied manifestations which is seen in nephritic and nephrotic syndrome. I'll touch on this point again when we are discussing about clinical manifestations. Let's continue with the etiopathogenesis. In etiopathogenesis, I was explaining about immune complex deposition in the subepithelial layer. And then this is the most common cause. Immune complex deposition is the most common cause, followed by the direct antibodies binding into the parts of glomerular basement membrane. Here the antibodies are directly binding. Here the immune complex is being deposited, and secondly we are having immune attack. Less than 5% of the disease occur by this mechanism, so it's rare. Most of the disease are due to immune complex deposition. The antigens which cause the development of these antibodies can be exogenous and they can be endogenous. The exogenous antigens are like streptococcal antigens, which are responsible for post-streptococcal glomerulonephritis, which we will discuss in a while. And then endogenous antigen example is lupus nephritis. That is nephritis seen in SLE, systemic lupus erythematosus, where the antigens are body's own DNA. They have anti-DNA, DNase, antibody, and other things. And the pathophysiology is very interesting. We will discuss it when we discuss rheumatology. So let me summarize etiopathogenesis of acute proliferative glomerulonephritis. The acute proliferative glomerulonephritis is most commonly due to deposition of immune complex followed by direct antibody binding into the glomerular basement membrane. The antigens which are causing the development of antibodies can be endogenous and exogenous. The exogenous antigen is the streptococcal, where we see manifestation as post streptococcal glomerulonephritis. The endogenous antigens example is lupus nephritis, which is seen secondary to SLE. So this is about acute proliferative glomerulonephritis etiopathogenesis. Let us see the clinical manifestation of acute proliferative glomerulonephritis. The clinical manifestations are hematuria. We don't see hematuria in nephrotic syndrome. Hematuria is seen in nephritic syndrome. Why we don't see hematuria in nephrotic, but we see in nephritic? It lies in the place where the attack occurs. Here the attack occurs at subendothelial layer, which leads on to development of nephritic syndrome and secondarily hematuria. In nephrotic syndrome, the podocytes and adjoining structures are involved, which are responsible for blocking proteins from leaking. So the major manifestation is proteinuria here. Here the major manifestation is hematuria. First clinical manifestation is hematuria, followed by red cell cast in urine. Hematuria will obviously lead on to red cell cast in urine because the Tom Hirschfeld proteins which are present, normally physiologically present inside the tubules. These proteins are like, think it as sticky pad. Whatever comes into the tubule, they bind to it, and we will see in the urine microscopy, and thereby helping in diagnosis of the disease. Here, since the RBCs are leaking at the glomerulus, the RBCs will come and bind to the sticky pads, Tom Hirschfeld proteins, and then we will see red cell cast in urine, followed by azotemia, that is temporarily. Any renal impairment will cause this, and then temporary oliguria due to decreased glomerular filtration rate due to tubuloglomerular feedback mechanism and other compensatory mechanisms. And then we see hypertension. Hypertension, why? I will explain when I am explaining about post-streptococcal glomerulonephritis, which is also the 5 marks question. Then we see proteinuria and edema are the least common manifestations seen in nephritic syndrome. So we mention it at last. The proteinuria and edema is not so severe as we see in nephrotic syndrome. So the first manifestation that you mention in nephritic syndrome is hematuria, azotemia, temporary oliguria, hypertension. The first manifestation that you mention in nephrotic syndrome is proteinuria, edema, thrombosis, followed by all these things. I think all of you have nicely understood what is the major etiopathological difference between nephritic and nephrotic syndrome, leading to different clinical manifestations. This is about acute proliferative glomerulonephritis or acute nephritis syndrome. I mentioned the antigens which are causing it can be exogenous and endogenous. If the exogenous, one of the example for exogenous antigen causing acute proliferative glomerulonephritis is post-streptococcal glomerulonephritis. So, and endogenous one is lupus nephritis. Lupus nephritis is also an important question since it's repeated only once. It's asked only once in RGHS. I am not discussing it due to time constraints. Please study it when you're doing self-study. So since PSGN is repeated so many times, I am explaining it now. I hope all of you understood the big picture view of glomerulonephritis. In glomerulonephritis, we have acute proliferative glomerulonephritis, rapidly progressive glomerulonephritis, chronic glomerulonephritis. In acute proliferative glomerulonephritis, we have lupus nephritis and post-streptococcal glomerulonephritis. We saw etiopathogenesis of acute proliferative glomerulonephritis, that is due to immune complex deposition, most commonly followed by antibody attack. And we all saw the clinical manifestation with their reasoning of acute proliferative glomerulonephritis. We'll proceed on to post-streptococcal glomerulonephritis. Please note, if the question is acute nephritic syndrome also, you answer will be same as acute proliferative glomerulonephritis. Please don't be confused with the terms. Let's continue with post-streptococcal glomerulonephritis. The post-streptococcal glomerulonephritis, we saw it's due to exogenous antigen causing immune complex deposition. First, we'll see post-streptococcal glomerulonephritis etiopathogenesis. What is the etiology of post-streptococcal glomerulonephritis? See, we all get streptococcal infection. Probably most of us have got streptococcus infection. Group A hemolytic streptococcus infection. But all of us don't develop PSGN. All of us don't develop rheumatic heart disease. Why? Because the people who have genetic predisposition will go on to develop the disease. All the people will not develop. The genetic predisposition leading on to this disease, this pathophysiology is also very interesting. Any other day we can discuss this. So genetic predisposition is very, very important. HLA-DR4 and DR1 association is most commonly associated with post-streptococcal glomerulonephritis. And then with this genetic predisposition, the patient should have infection for him to develop this disease. That is group A streptococcus infection. The skin infection will most commonly lead on to PSGN than sore throat, meaning skin infection is most commonly associated with it than sore throat. The strains causing skin infection which lead on to PSGN are 49, 47, 55, 57. Where the number 49 is important. Our Ritik Raj roll number 49. 49 strain is very important. It's implicated with PSGN. The other one we have sore throat. The strains seen are 12, 1, 2, and 4. The strain 12 is most important one. You can remember only one of the strains and manage in the exams. Following sore throat, after 7 to 10 days, we see glomerulonephritis. Following skin infection, after 2 to 4 weeks, we see glomerulonephritis. Now, why these people develop glomerulonephritis? Streptococci has 2 antigens. It has many antigens. I am mentioning the most important one which are relevant to us. That is nephritis associated plasmin type 2 receptor and streptococcal pyogenic exotoxin B. So in the people who are genetically predisposed, these people are genetically, their immune system tuned to produce antibodies against these 2 antigens. That is nephritis associated type 2 receptor and streptococcal pyogenic exotoxin B. So these genetically predisposed individuals will develop antibodies against these 2 proteins, these 2 antigens. Now these immune complex will be formed inside the blood. T cells will form antibodies. The antigens will be lying inside the blood. The bacteria thriving inside the blood happily. These 2 will bind to each other and cause disease, ruckus inside the kidney. The immune complex deposition occurs in subepithelial layer in case of PSGN. I mentioned here that most commonly subendothelial layer nephritic syndrome is seen. That is most common one. In PSGN, the deposition occurs subepithelial layer. layer most commonly. So the immune complex will be deposited. The immune complex present in the blood will go to the kidney. They will get deposited in the subepithelial layer of glomerular basement membrane. And then following that, our immune cells who are ready will come and attack our glomerular basement membrane, leading on to the immune-induced damage, that is glomerulonephritis, acute glomerulonephritis. So we saw the pathology of PSGN, that is immune antibodies production against nephritis associated plasmin type 2 receptor and streptococcal pyogenic exotoxin B. These antigen antibody will bind inside the blood. It will come and deposit in the subepithelial layer of glomerular basement membrane. Our immune cells will come and attack these subepithelial deposits, and then leading on to clinical manifestation. So in the inflammation, we see both B cell and T cell reacting to it, and also the alternate complement pathway is most commonly activated in case of PSGM. Under investigation, when we are doing investigation, the 90% of patients have reduced C3 levels. It's an important point. We'll come to it when discussing investigations. So this is about etiopathogenesis of PSGN. We saw genetical predisposition, infection, followed by immune attack. Let's go on for clinical manifestations. The clinical manifestation of post-streptococcal glomerulonephritis are, they have classical triad of cola-colored urine. This question was asked repeatedly in our pathology days. And we see oliguria in this patient and also hypertension. Now you may ask, why hypertension in case of AKI? Sorry, PSGN. Let me explain. The nephritis associated plasmin type 2 receptor, the antigen which I told you, this will go and bind to this along with plasmin will go and activate ENaC channels. What are these ENaC channels? ENaC channels are channels present on the DCT, which are stimulated by aldosterone, causes sodium and water reabsorption. So when these ENaC channels are activated, it causes increased sodium and water retention inside the body. We know that increased sodium and water retention inside the body will cause hypertension, and also due to water retention we can also see pulmonary edema. This is the pathology behind development of hypertension. We saw the classical triad in PSGN, that is cola-colored urine, oliguria, and hypertension. And also along with that we have pulmonary edema, which we discussed. In any AKI, acute renal failure, we see hyperkalemia due to renal impairment, and also the diastolic blood pressure is impaired, and it may lead on to posterior reversible encephalopathy syndrome, the CNS manifestation of hypertension, acute hypertension, which may cause seizure in the patient. Now we discussed clinical manifestations and pathophysiology. Under clinical manifestation, we saw classical triad, cola-colored urine, hypertension, oliguria, pulmonary edema, and then hyperkalemia, diastolic blood pressure impairment leading on to posterior reversible encephalopathy syndrome, which may present as seizures in patient. This is about PSGN clinical manifestation. Let's see management of post-streptococcal glomerulonephritis. The post-streptococcal glomerulonephritis investigations are, we see in all the patients who present with renal failure, we do renal function test. We see mild impairment in parameters which are tested in renal function test. The parameters are severely impaired in case of RPGN, that is rapidly progressive glomerulonephritis. We see only mild impairment in renal function test. And when we do urine routine, we all know that we will see RBC casts WBC cas due to inflammation. Albumin may be 1 plus 2 plus. Proteinuria is minimal. These are the basic investigations that we do in PSGN. Now, coming on to renal biopsy. Renal biopsy we don't do in all patients. Renal biopsy will do only when for more than 8 weeks. If we see reduced C3 levels, reduced C3 because in PSGN we saw the alternate complement system is activated, which consumes C3 protein. So if the C3 is reduced for more than 8 weeks, then we should consider renal biopsy. And also in case of recurrent episodes of PSGN, we should consider a renal biopsy. Now, what are the findings in renal biopsy? We have histopathological findings, immunofluorescence findings, and electron microscopic findings. The histopathological findings are diffused proliferative glomerulonephritis, that we see proliferation of the cells, increased number of cells, which I explained previously. In immunofluorescence, we see granular deposits, that is starry pattern. And under electron microscopy, we see subepithelial camel hump deposits. These are all facts you can remember, and also you can remember it by connecting it with previously mentioned points. These are all about investigations. In investigation, we saw RFT, which is mildly impaired, urine routine, and biopsy in some cases only. And then we move on to treatment of post-streptococcal glomerulonephritis. Post-streptococcal glomerulonephritis, with time, it subsides by itself. We should only manage the complications or the manifestations that we see in post-streptococcal glomerulonephritis. We see hypertension. Hypertension is managed by amlodipine to 2.5 to 5 mg, and also regular BP. BP should be monitored every 1 hour. Please note this point. BP should be monitored every 1 hour, because if the BP is not adequately controlled, it may lead on to PRESS syndrome, that is posterior reversible encephalopathy syndrome. And also we see pulmonary edema. Pulmonary edema is managed with diuretics, that is toracimide, and also hyperkalemia will manage with calcium gluconate. This is about the treatment of PSGN, that is post-streptococcal glomerulonephritis. I will summarize post-streptococcal glomerulonephritis. We saw pathophysiology. Under pathophysiology, we saw etiology. Etiology is genetical predisposition and infection, sore throat and skin infection. Under pathology, we saw immune complex deposition and immune attack. And then we saw clinical manifestations. Under clinical manifestation, classical triad, pulmonary edema, hyperkalemia, and PRESS syndrome. And then we saw management, investigations, renal impairment, urine routine, biopsy. We saw the management of hypertension, pulmonary edema, and hyperkalemia. This completes the discussion on post-streptococcal glomerulonephritis, acute nephritis syndrome. Now, until now, we completed 2 topics, that is acute nephritic syndrome and acute glomerulonephritis. And also, when you are writing about acute nephritic syndrome or acute proliferative glomerulonephritis, you can mention the investigations and treatment of PSGN. You can do that. And also you can quote the PSGN and lupus nephritis as examples for acute proliferative glomerulonephritis and elaborate on these 2 separately. So this is about these 2 topics. To see is hematuria. It's repeated 3 times. Hematuria. Hematuria, the term itself tells that it's nothing but excretion of excretion of blood in urine, RBCs in urine. Hematuria can be of 2 kinds. It can be macroscopic. It can be macroscopic or microscopic. The macroscopic one is called the overt hematuria, and microscopic one is called Microscopic hematuria. Hematuria, two types. Macroscopic one, where the patient complains of passing bloody urine, and the microscopic one, where the patient doesn't complain about passing blood RBCs in urine or blood in urine. We see RBCs on dipstick or on doing microscopic examination. Now, what are the causes of hematuria? The causes of hematuria are pretty straightforward. Based on the site of bleeding, we can classify the causes of hematuria. I'll share you the hematuria be due to involvement of renal pelvis or lower urinary tract, where pink or red colored urine are seen. Is seen. It may be due to involvement of ureters. Let me go according to anatomical site. From glomerulus, I'll start. If the glomerular pathology is present, we see macroscopic hematuria. We saw in PSG and that we see cola colored urine due to excretion of red blood cells substances. We see macroscopic hematuria, microscopic or macroscopic hematuria in case of glomerular disease, and then followed by that we can have diseases in the renal pelvis and the ureter. There may be stone in the renal pelvis and ureter, which is breaching the epithelium, leading on to hematuria. And also, there may be bladder pathology, which lead on to hematuria. There may be bladder carcinoma, which is leading on to hematuria. There may be cystitis, leading to hematuria. There may be any other proliferative growth inside the benign growth inside the bladder, leading on to hematuria. And also schistosomiasis, other things. And also, followed by that, we have urethra. We know that urethral injury, in case of urethral injury, we can see hematuria and blood at the tip of meatus, etc. So these are all the probable causes of hematuria. Based on the site, based on the some features, we can think that this may be the site. If the color of the urine is pink or red, then a renal pelvis or lower urinary tract is involved. Blood is present only at the end of micturition, most probably prostate or bladder base is involved. If the lower urinary tract is involved, there are isomorphic erythrocytes. Now, what are these isomorphic erythrocytes? See, if the hematuria is due to glomerular basement membrane disease, like case of acute nephritic syndrome and other syndrome, here we have inflammation. This is endothelium, lamina densa, and we have podocytes. So we have subendothelial injury, and here, in order to come to the urine, the RBCs should maneuver through the defect and come to urine. So during this process, the RBC's membrane structure will get distorted. In case of lower urinary tract origin, there is no such thing like this. So there will be isomorphic erythrocytes in urine on urine microscopy. And also microscopic clots of clumped erythrocytes may be present in urine if the lower urinary tract is involved. So if it is glomerular origin, we see cola colored urine. We already saw cola colored urine in PSGN. There may be red cell cast. We all know that. Dysmorphic erythrocytes, I mentioned here while explaining about this. There can be acanthocytes. What are acanthocytes? Erythrocytes with one or more membrane protrusions of variable size and shape. Due to this manuring, the RBC's shape may get distorted. It leading on to membrane protrusion. If it happens, it's called acanthocytes. This is seen in glomerular origin. If the disease in glomerular origin, and if it's urinary bladder or above, we see blood diffusely present throughout the urine. If it is bladder or above, we see blood diffusely present in the urine. If it is prostate or bladder base, we see blood at the end of micturition. If it's at the urethra is involved, blood is seen in the start of boiling and then urine becomes clear. So I mixed up all this table from starting from here. I'll explain once again. If the bleeding is in glomerular origin, you remember we see cola colored urine, RBCs, dysmorphic RBCs, and acanthocytes. If the origin is in renal pelvis or lower urinary tract, we see pink or red colored urine. If the bladder base or urinary bladder or above is involved, we see blood diffusely present throughout the urine, because as the urine dribble down through the ureter and down the urinary bladder, it will carry the RBCs along with it. If the prostate or bladder base is involved, we see blood only at the end of micturition. The reasoning of which we will understand when we study surgery urology. There I'll mention the reasoning. If the lower urinary tract is involved, we know isomorphic erythrocytes are present, microscopic clots present in urine. So this is about the sites and characteristic features of hematuria. We saw what is hematuria, macroscopic, microscopic, and then we saw what are the causes of hematuria and what are the probable insights, which gives you the idea which part of renal tract, which part of urogenital system is involved. This is about hematuria, and also we have another question: what are the causes of painless hematuria? Painless hematuria we see where the nociceptive receptors or pain receptors are not present. We all know that glomerulus is not so pain sensitive. So in glomerulonephritis, we'll see painless hematuria. In pyelonephritis, severe acute pyelonephritis due to renal abscess and all, we don't see pain in case of hematuria. In case of RCC, renal cell carcinoma, we don't see pain. In case of other conditions like infective endocarditis, renal tuberculosis, vaginal granulomatosis involving kidney, will not see pain. And also, if there is a neoplasm in the ureters, we won't see pain until and unless the surrounding nerve structures are involved. In case of bladder neoplasm, also we don't see pain. And in case of prostatitis, prostatic neoplasia, urethral trauma, we won't see pain. Almost all causes are painless causes of hematuria. The one cause where you see pain and hematuria, which I can recollect now, is stones in the ureter and renal pelvis causing hematuria. We saw the types of hematuria, causes and characteristic feature, causes of painless hematuria, and at last I want to mention the only one important point about hematuria. If there is macroscopic hematuria, what is macroscopic? Macrohematuria, not macroscopic hematuria, sorry. Macrohematuria. Macrohematuria is different from macroscopic hematuria. Macrohematuria, if it is present, when we'll say it is present, means if more than 40% of RBCs present in the examination are dysmorphic, if we see more than 5 acanthocytes, if we see even one RBC cast, we call it as macrohematuria, not macroscopic, macrohematuria. We see it most commonly in IgA associated nephropathy. If any one of these things are present, we call macrohematuria, and macrohematuria is one of the indication of biopsy, and also along with that, asymptomatic disease is there. I will not go into it. So I want you to remember one point. Macroscopic hematuria is different from macrohematuria. Macrohematuria is defined by more than 40% of dysmorphic RBCs, more than 5 acanthocytes, more than 1 RBC cast, which is most commonly seen in IgA nephropathy. We will do renal biopsy in this case. To summarize, I talked about hematuria, types, macroscopic and microscopic, and I also talked about macrohematuria, which is the indication of biopsy. I talked about various structures which can be involved, that is glomerulonephritis leading on to hematuria, the renal pelvis and ureter stones leading on to hematuria, urinary bladder neoplasm leading on to hematuria, urethral neoplasms and urethral trauma leading on to hematuria. Causes of painless hematuria, glomerulus, RCC, ureters, tumor, bladder tumor. This is about hematuria. This is a 5 marks question and also sometimes asked as 3 marks question. I think this is hematuria is clear. Next, we'll move on to next topic. We are done with hematuria. Now we will go on to minimal change disease, which is asked twice in RGHS. Before that, all other questions are asked once or twice, except for CKD. We already discussed acute renal failure. Already discussed. All other questions are asked once or twice. Okay. We'll discuss minimal change disease, good pasture, polycystic kidney disease, renal vascular hypertension, and other diseases. Only twice it's asked. We'll discuss briefly about minimal changes. It's an important topic for NEET PG. We'll discuss next year. We can discuss it during internship time deeply, but I'll mention it briefly now. Okay, don't get all overwhelmed by this mind map. I'll break it for you. Under glomerular pathologies, based on anatomical classification, we can classify it as disease involving glomerular basement membrane and disease involving mesangium. Glomerular basement membrane, we know we have podocytes. There are 3 diseases which involves podocytes, that is minimal change disease, FSGS, focal segmental glomerulosclerosis, and membranous nephropathy. Out of these 3 diseases, I am discussing minimal change disease now. Minimal change disease, which is a podocytopathy. Minimal change disease, etiopathogenesis. Commonly, it's seen secondary to drug intake, that is NSAIDs, TNF alpha inhibitors, and then intake of gold. And secondary to malignancies like Hodgkin's disease and also cutaneous T-cell lymphoma or CLL, chronic lymphoid leukemia. And also it's seen in people with atopy and allergy secondary to allergy to any drugs. I'll see what are the drugs. I'll once again mention the causes of minimal change disease. Intake of drugs, NSAIDs, which causes minimal change disease more than membranous nephropathy, and then interferon alpha. I think I mentioned other one. Then gold, and then followed by malignancy, which is Hodgkin's disease, chronic lymphocytic leukemia, and allergy. If the patient have atopic rhinitis, atopic dermatitis, asthma, or post-immunization allergy, these patients are more prone to develop minimal change disease. Now, why the term minimal change disease? Actually, the term is self-explanatory. When we perform renal biopsy, we don't see much manifestations. The glomerulus will be fine. The tubules will be fine. Since there are no clinical manifestations, since there are no histopathological changes seen on renal biopsy, we call it as minimal change disease. But on electron microscopy, we will see the loss of podocytes, that is podocytopenia. One of the most important point to remember is If there is podocytopenia, the podocyte loss will lead on to CKD eventually. Yesterday I explained it but didn't stress this point much. I want you to remember that FSGS and membranous nephropathy will lead on to CKD, and minimal change disease will not lead on to CKD commonly because it doesn't cause a reduced number of podocyte cells. Then what it causes? The T cells, dysregulated immune system, the T cells will attack podocytes. There will be loss of charges inside of the podocytes. This loss of charge will lead on to protein loss. We all know that the negative charge present in the glomerular basement membrane, I think negative only, yes. The charge present in the glomerular basement membrane is responsible for preventing protein from by being excreted in urine. So loss of this charge will lead on to proteinuria. We saw minimal change disease is one of the most common cause of nephrotic syndrome in case of children's. The pediatric nephrotic syndrome in 80% of cases is due to minimal change disease because we see loss of charge, podocyte injury, and proteinuria, which leads on to most commonly nephrotic syndrome. And also, in case of adults, minimal change disease, 20% of nephrotic syndrome is due to minimal change disease. This is about etiopathogenesis of minimal change disease. Etiology is drug intake, malignancy, allergy, and then pathology is dysregulated T cells leading on to podocytes injury and proteinuria. Now, what are the clinical manifestations seen in case of minimal change disease? We have 100 to 0 rule. Every patient of minimal change disease will have nephrotic syndrome. This rule is mentioned because in other we have 30-40 rule and some other rule in FSGS and membranous nephropathy, which means around 10% of patients with membranous nephropathy develop RPG and 35% develop nephritic, 35% develop nephrotic syndrome. Like this, we have different percent. But in case of minimal change disease, 100% of patients will develop nephrotic syndrome. This is very important point to remember. So, due to nephrotic syndrome, we will see the manifestations of nephrotic syndrome: hypertension, acute kidney injury, and hypertension, acute kidney injury, and microscopic hematuria is absent in these patients. Why this is absent? Nephrotic syndrome will rarely lead on to AKI due to loss of effective intravascular volume. It is a rare complication, not commonly seen. But in minimal change disease, nephrotic syndrome is not associated with AKI. If you see hypertension, AKI, and microhematuria, you can be pretty sure that it is not minimal change disease. What are the clinical manifestation of minimal change disease now? The clinical manifestation of minimal change disease is of nephrotic syndrome, that is generalized edema, anasarca, thrombosis manifestations, dyslipidemia, and then other manifestations. This is about clinical manifestations. Then we have management. 1 minute. Okay, we'll go on for management. The treatment of minimal change disease in case of nephrotic treatment of minimal change disease. Before that, for investigations, you can write the common investigation, that is renal function test, and other investigation that we mentioned in nephrotic syndrome. You can copy from nephrotic syndrome and paste it here. Before mentioning the treatment, I'll mention few important points about minimal change disease. It's also called lipoid nephrosis. 90% of childhood nephrotic syndrome is due to minimal change disease. I mentioned it 80% because it's mentioned in textbook as like that. 10 to 15% of adult nephrotic syndrome is due to minimal change disease, seen in boys more than girls. Peak age is 2 to 7 years. Non-selective proteinuria is seen, which all we discussed previously. The changes in podocytes are, you can remember effacement of food process, or you can remember loss of negative charges. Yes, loss of negative charges leading on to proteinuria. There is selective proteinuria, loss of only albumin and transferrin is seen in few minimal change disease. And then the treatment is same as the treatment of nephrotic syndrome. We give steroids, that is 2 mg per kg per day in case of children, 1 mg per kg per day in case of adults. If there is steroid resistance, which is seen in 5 to 10% of patients, will do renal biopsy and look out for other causes and treat accordingly. And also in case of steroid resistance minimal change disease, we can give calcineurin inhibitors, that is cyclosporin, tacrolimus and sirolimus. Those who respond to steroid, 25% are cured without any relapse, 25% show infrequent relapse. We give them steroid and taper it off during the relapse, and 50% of them will develop frequently relapsing nephrotic syndrome. All these points deeply we'll discuss when we discuss these systems while studying for NEET PG. For now, this much deep is not required. Only twice it's asked minimal change disease. I will summarize minimal change disease now. Idiopathogenesis. It's seen secondary to drug intake, malignancy, allergy, pathology, immune dysregulation leading on to podocyte injury, which causes charge loss and proteinuria, and leading on to clinical manifestation. Characteristically, remember 100% rule, where 100% of patients have nephrotic syndrome as manifestations, unlike other diseases, that is FSGS, membranous nephropathy, IgA nephropathy, and all. And also, the clinical manifestation, you can mention the clinical manifestations of nephrotic syndrome that we have discussed yesterday. The cystic diseases of kidney. The name itself tells that there are cysts in kidney. It's a familial disease. There are importantly two types. Polycystic kidney disease is of two types. That is autosomal recessive polycystic kidney disease and autosomal dominant polycystic kidney disease. Autosomal recessive polycystic kidney disease is due to mutation in PKDH1 gene, whereas autosomal dominant polycystic kidney disease is due to mutation in PKD1 and PKD2 gene. These are the mutations that we see in these two diseases. Autosomal dominant polycystic kidney disease is most important in case of manifestation, also in exams. Autosomal recessive, I will mention few important points, and we'll go on to proceed on to discussion of autosomal dominant polycystic kidney disease. The autosomal recessive polycystic kidney disease, I already told there is mutation in PKHD1 gene on chromosome 6 that encodes for fibrocystin and biliary epithelial tissue. This is very important. It encodes for fibrocystin in biliary epithelium also. Since these genes are important in biliary epithelium also, the ARPKD patients are associated with congenital hepatic fibrosis and intrahepatic bile duct dilation. That is due to biliary epithelium impairment. They have hepatic manifestations and renal manifestation. Renal manifestation is cystic kidney disease, and hepatic manifestation is congenital hepatic fibrosis and also intrahepatic biliary duct dilatation. These are few points important under ARPKD, PKHD1 gene. Okay. ARPKD, PKHD1 gene, hepatic and renal manifestation. Renal manifestation is cystic disease. Clinical manifestation we see when we discuss ADPKD. But also we have hepatic manifestation, that is due to impairment of fibrocystin, which is encoded by this gene in the biliary epithelium. We see hepatic manifestation as congenital hepatic fibrosis and intrahepatic bile duct dilatation. This is about ARPKD. And then we see ADPKD, that is autosomal dominant polycystic kidney disease. Before discussing about ADPKD, I want to discuss about a concept. What happens in this cystic kidney disease is very, very interesting. We have microvilli on top of this tubules. Okay, these cilia centromere complex, when they move, I am zooming in. Wait, 1 minute. When they move back and forth, they stimulate some genes, and they are associated with some physiological processes which ensure the normal architecture of tubular epithelium. The cilia and centromere normal movement ensures the normal architecture of tubular epithelium. When this is impaired in case of genetic mutation, PKDH1, PKHD121, PKD1 and D2 genes, this lead on to impaired architecture of tubules, which is presenting as cyst and secondary complications. So the impaired cilia centromere complex is seen in case of ADPKD, ARPKD, and juvenile nephronophthisis, which is important for NEET PG. We will be discussing later. The ADPKD. Coming on to etiopathogenesis. Etiology will know genetic mutation of PKD1 gene and PKD2 gene. PKD1, there is impairment of polycystin protein, and PKD2, PKD3 gene are mutated. This leads on to impaired function of cilia, which lead on to impaired architecture. Impaired architecture lead on to development of cyst. Now, what this cyst does? The volume of renal parenchyma is limited. It's not unlimited. When these cysts develop, when they dilate, they compress upon normal glomerulus. This masum glomerulus are present normal functioning. This enlarged cyst will compress upon this normal glomerulus and cause the damage of normal glomerulus. Due to the damage of normal glomerulus, will eventually develop CKD. We all know this. Yesterday we discussed idiopathogenesis of CKD. So, in 60% of patients, by 60 years, they develop CKD due to this mechanism. And also, there may be secondary cyst complications like there may be hemorrhage into the cyst may rupture, and other things may occur. We'll discuss it in the clinical manifestation. Now, the etiopathogenesis is genetic mutation and impaired cilia function leading on to impaired architecture, cyst development, and secondary complications and CKD. This is about ADPKD etiopathogenesis. And also in ADPKD, we have extra renal manifestations. Extra renal manifestations are cysts in other organs like liver, spleen, pancreas, thyroid, and also we can have berry aneurysm, mitral valve collapse, etc. Just remember 1 to 3 extra renal manifestations. The most important are cyst in the brain and berry aneurysm. Now, why these blood vessels are involved? The prostacyclin, which is mutated, will cause reduced nitric oxide, which impairs the functioning of architecture of blood vessels, and thereby the diseases related to blood vessels like berry aneurysm and other disease. So about etiopathogenesis of ADPKD, let's proceed on to clinical manifestations. Clinical manifestation, most of the ADPKD patients are asymptomatic. They are usually picked up on doing ESG for other purpose. In the symptomatic patients, we see abdominal discomfort, rhinomagaly, When the cyst enlarges, there can be renomegaly leading to secondary discomfort. And usually the patients present with renomegaly and abdominal discomfort in 20 to 40 years age group. And also, most importantly, the patient has hypertension. Hypertension. Hypertension is very important here because if we adequately treat hypertension, if we adequately manage hypertension aggressively, we have criteria for it. Aggressively managing the hypertension will reduce the progression of disease, and it's associated with better outcomes. The patient may also have due to cyst nocturia and polyuria. These are the renal manifestations. Now, what are the complications? We saw end-stage renal disease. 60% of the patients with ADPKD will develop end-stage renal disease by 60 years of age. And also, the bad prognostic markers are there. I don't think this is necessary now. And other complications are complications related to cyst. There may be stones developing inside cyst. The cyst may rupture, leading on to acute abdominal pain. Cyst may get secondly infected with E. coli. We use commonly 3Cs antibiotics, that is carbapenem, ciprofloxacin, cotrimoxazole. If you want, you can remember this. And also, the patient may also have cyst hemorrhage. The cyst which has developed, there may be hemorrhage into the cyst. This lead on to acute abdominal pain. The other important cardiac manifestation is biventricular diastolic failure. I will explain about heart failure when we discuss cardiology. So this is about renal manifestations and associated complications. Extrarenal manifestations are cysts in hepatic system and aneurysm. So to summarize clinical manifestations, most of the patients are asymptomatic, picked up on USG. If the patients are symptomatic, we have abdominal discomfort, hypertension, nocturia, polyuria, complications as ESRD, complications related to cyst, and also biventricular diastolic failure. Extrarenal manifestations are cysts in liver and aneurysm. Now, what are the investigation findings in ADPKD? If you do RFT, renal function test, it will be normal in most of the patients until and unless they have developed end-stage renal disease. On USG, you can see cysts. We have criteria called Ravinson's criteria. We can only mention the name of the criteria and proceed with our answer. Under treatment, the very important one is reducing the osmolarity of urine. Now, how to reduce the osmolarity of urine? How urine osmolarity is maintained? I will briefly touch upon the physiology points. ADH, which is present in ADH, which is released by posterior pituitary, will act on collecting duct to express aquaporins, which leads to reabsorption of water reabsorption. This water reabsorption is responsible for reducing osmolarity of urine. So if we block the action of ADH, that is antidiuretic hormone, we can reduce the osmolarity of urine by increasing the water excretion. I hope all understood this. I'll explain once again. When we block the function of antidiuretic hormone, there are no aquaporin expressed in collecting duct. This leads to reduced water reabsorption, increased water excretion. Increased water excretion will cause reduction in osmolarity of urine. So this reduced osmolarity of urine is associated with reduction in size of growth of cyst. So we recommend reducing the osmolarity of urine by giving V2 antagonist, that is the ADH receptor antagonist, tolvaptan. And then other important management point is BP control, aggressive BP control. I told that it reduces the severity of disease with time. The systolic BP should be tightly controlled between 75 to 110 mmHg. The diastolic BP should be controlled between 60 to 75 mmHg. And at last, if the patient has end-stage renal disease, we can't help. We'll proceed on with renal transplantation. This is about treatment. I will summarize Polycystic kidney. Polycystic kidney is divided into ARPKD, ADPKD. ARPKD is associated with mutation of PKHD1 gene, associated with renal and hepatic manifestation. Then we have ADPKD, most commonly C1, most commonly asked question. Etiopathogenesis, gene mutation PKD1, PKD2, PKD3, and pathology. We have ciliary impairment leading on to impaired architecture, which leads on to cyst development, and cyst development will lead on to CKD and other secondary complications. The impaired prostacyclin in gene will lead on to reduced nitric oxide and impaired architecture of blood vessels, leading on to perianeurysm and other vascular manifestation. And clinical manifestation, we have most of the patients are asymptomatic, some are symptomatic. The renal manifestation are abdominal discomfort. Please remember, it's abdominal discomfort due to renomegaly, and then hypertension, nocturia, polyuria. Complications, we have ESRD, and then complications related to cyst and biventricular diastolic failure. And then we went to management investigations, impaired RFT, USD criteria, Ravinson's criteria. Treatment, we have to reduce osmolality by giving tortone, and then we should aggressively control the BP between SBP and DBP. We have criteria, and then if the patient has end-stage renal disease, we proceed on with renal transplantation. This is about cystic kidney disease